Today's lecturer and speaker is Professor Dickon Hayne, and he's going to be talking to us about urological cancers. Dickon studied medicine at St Mary's in Paddington and remained in London for his basic surgical training and completed a medical doctorate investigating the side effects of radiotherapy for urological cancer at University College. He is the clinical academic who leads the urological research team within the School of Surgery at the University of Western Australia. He is responsible for the undergraduate education on urology at the University of Western Australia. He works as a consultant urological surgeon at Fremantle Hospital. He's deputy chair of the bladder cancer subcommittee of the Australian New Zealand urogenital and prostate cancer trials group, and is widely engaged in a range of committees that do work in this space. He's very much a leading urologist here in Western Australia and nationally, involved in Urological Tumour Collaborative in the WA Cancer and Palliative Care Network, and is chair of the new charitable organisation in Western Australia and the Urological Research Organisation. His major clinical and research interests are urological cancers and particularly cancer of the bladder. So please join me in welcoming Professor Dickon Hayne.
Thanks very much, Terry, and good afternoon to you all. So, what we should know about urologic cancers, and I'd like to thank the Cancer Council for the title of the lecture, which was there. Now, Terry's gone through a lot of this, so I'm obviously mainly involved with the University of Western Australia and Fremantle Hospital, where I work as a clinical academic. There is a new organisation which is specifically dedicated to research for urologic cancers, and particularly with a surgical bent, which I'm the chair of that organisation. And as he mentioned, involved with the Cancer Network, ANZUP. I'm obviously a fellow of the USANS, which is the urologist group in Australia, and also the Australasian College of Surgeons. So what are urologists? There's some discrepancy about what people think about urologists, and we've had a lot of talk in our own society about whether we should actually tell people that we're surgeons or not. But we are primarily surgeons, so we're involved with any operation for treating diseases of the urinary and genital systems. But by the nature of the disease processes that we get involved with, we do also have to carefully assess patients clinically, and also we do prescribe quite a few drugs, which makes us one of the more medical of the surgical specialties. So what conditions do we treat? Well, first of all, cancer. In fact, urologists actually see more cancer than any other specialty. So because we cover quite a wide range of different organs, we actually deal with the most cancer through our doors, except for perhaps the dermatologists who cut off little skin lesions and also treat the surgeons who treat skin cancer. So prostate cancer, bladder, kidney, testis, and penis. Those are the five main ones, and those are listed in order from the very, very common to the very rare. And then the other stuff we do is look after kidney stones, look after enlarged prostate, so that's a benignly enlarged prostate that doesn't have cancer. We look after patients with incontinence, urinary incontinence, and also men who have erectile difficulties and some sexual difficulties. And then any other anything else that goes wrong with the urinary or genital systems that requires surgery. And I will go into a little bit more detail about what I mean by the urinary and genital systems. And as surgeons, we have quite a broad remit. So we get to use lots of different sorts of bits of kit and approaches to our operations. So we do open surgery, where we actually have to physically make a cut to access the areas that we're operating on. We also do a lot of endoscopic surgery, operating down telescopes into the bladder, and also very small telescopes that can go all the way up through natural orifice, natural holes, so either through the penis or through the urethra in the woman, all the way up the ureter and up to the kidney to laser stones or to look for tumours or whatever it may be. And we also do get involved in keyhole surgery, as well as open surgery to quite a large extent. So it's quite a varied surgical practice. And it takes a long time to get the hang of all that. So if you want to be a urologist, you have to start young. That's why I said to my daughter, I didn't expect her to start reading the BMJ at 2, but that's what she did. Now, just to go through some of the anatomy of the things that we're going to be talking about. So this is sort of a representation of both the urinary and the genital system. So We have the kidneys. The kidneys make urine. They pass urine down the ureters and into the bladder, where the urine is stored, and then at a convenient moment, hopefully, it's voided through the urethra. The female anatomy is similar, but they don't have a prostate here, and they have a much shorter urethra. This is just a representation of a kidney, so there might be a stone sitting in the kidney. That might be what we're interested in. That could be a tumor that we need to have a look at in the kidney. And if we look on this, this is just a slightly more detailed section in two different planes. We can see here the testis outside the body. We've got the bladder, the urethra, the tube that runs from the bladder to the outside world. And then there's these nice tubes that carry the sperm from the testicles around into the prostate, and then they come out when you ejaculate. And these things are called seminal vesicles. These are the bags that make the rest of the fluid that comes out when you ejaculate. So most of the ejaculate isn't actually sperm. Most of it is actually fluid that comes from these bags called the seminal vesicles. Okay. So these are, again, the 5 cancers. Now, I've slightly cooked these numbers. That's really to help me remember them as much as anything else. I don't really think any of you are going to try and remember them. But this is really from prostate cancer to penile cancer. So prostate cancer really is very, very common. The commonest male cancer and the second commonest cause of male cancer death. 100 per 100,000. So this is new cases per year. So that's the same as 1 per 1,000. If we get to bladder cancer, the next most common, 21, kidney 14, testis 7, and penile only 1 per 100,000. So that's the rarest of all the urologic cancers. You can see this loosely represents the 7 times table, which helps me remember it. And then I just wanted to before we start on all the specifics of the different urologic cancers, I just wanted to talk about some of the general principles of treating all cancers, which we need to employ if we're actually going to get it right. So the first thing is that cancers are not all the same, and also many, in fact, technically, most cancers are curable. In order to do the job properly, you need to know how aggressive the cancer is. And aggressiveness we measure by something called grade. So grade is when you take a piece of the tumor, which may have been taken with a biopsy, or it may already be a whole organ or specimen that a surgeon's removed, and they give to a pathologist, and the pathologist looks under the microscope at the cancer cells and tells you how nasty they look. And it's really this aggressiveness that gives you a lot of information about how you're going to have to, whether you may need to give that patient additional treatment in order to try and have the best chance of cure. And of course, the other thing you need to know before you can even start is also the stage. So if cancer is just localized in one place, it's very amenable to cure, and often that can be achieved surgically. If the cancer is actually spread to other sites, then it may no longer be curable, or certainly to achieve cure, you may have to involve more things such as chemotherapy, radiotherapy, as well as surgery. So in general, if it's low grade and low stage, then that's good. That's what you want if you've got cancer. And the earlier you catch it, the better. And this is true really across all cancer sites. Some apologies for this slide, which is a little bit unpleasant. So blood in the urine is something that I do want to spend a little bit of time talking about. Blood in the urine is also called hematuria. And hematuria is a very, very significant symptom of cancer. Compared to all the other, you may have heard of some other symptoms of cancer, such as seeing blood in the poo or noticing lumps or bumps anywhere. This particular symptom, if you can see blood in the urine, is the most predictive of cancer of any symptom. Now, that doesn't mean if you've had blood in the urine that you've definitely got cancer, but it means you've got a significant chance and you should be investigated. So we're talking about 1 in 5 people that see blood in the urine actually ending up with a cancer diagnosis. And also, all of these 3 cancers can sometimes present with blood in the urine, but it does tend to be a symptom of bladder cancer. That's certainly the commonest cause of blood in the urine. Now, this is very important. Blood in the urine is concerning for urological cancer in any case. But if you can see the blood, there's a much higher chance that it is actually associated with urological cancer than if you happen to have just a small amount of blood that's been detected by a doctor on a dipstick or on a urine test. Okay? And it's in the order of, so people who get referred to see a specialist with these issues, about 20% of these, so a fifth, might end up having cancer, whereas if it's only on a dipstick and those who get referred to a urologist, maybe 5% or 1 in 20 will end up having a diagnosis of cancer. But it always warrants investigation. So unfortunately, it's not just going to your doctor, but your doctor really needs to send you to see a urologist. And don't forget that most people won't have cancer, but all the other conditions that cause blood in the urine, things like kidney stones, you actually need to treat those anyway. So it really is worth finding out about it. And this is the most important thing that needs to be done to investigate blood in the urine. So this is a flexible cystoscopy. You can see the surgeon here looking down the eyepiece. Mostly now we'll either have video cystoscopes or a little camera that goes on the end here, which means this very not bothered chap who's sitting here quite happily having this investigation can actually watch what's going on while the surgeon's doing the cystoscopy. So it's all done under local anesthetic. It's a very, very straightforward, safe test that takes about 20 minutes to do. And this is a flexible cystoscope. And this is the catheter, which is the normal drainage tube that you'd put into the bladder if you needed to drain it for any reason. You can see it's exactly the same size. In fact, if anything, putting this in should be less traumatic than putting that in, because this one's steered in under direct vision. So it's slightly uncomfortable. It takes about 2 minutes. It's a very safe test. For women, it's slightly unpleasant to have somebody looking down your urethra and into your bladder, the same as for chaps, but at least the urethra is a bit shorter, so it's probably even less uncomfortable. So it really isn't a nasty test to have. And having looked in the bladder to make sure that there's not a bladder tumor, and incidentally, the only way to pick up bladder cancer is to physically look. That's not quite true, but the only way to reliably exclude bladder cancer is to physically look in the bladder with a telescope. But in addition, we do some other tests in order to check there's no other things that might be causing bleeding in other parts of the urinary tract. So a CT scan, I'm sure most of you have heard of CT scans. We do a particular sort of CT scan where we give contrast into a vein which lights up certain areas in the urinary tract and helps us to look for disease in those. Just going to show you a little bit of data. So this is the clinic that I run at Fremantle Hospital, which is dedicated to the investigation of patients with blood in the urine. And it just gives you an idea of what we actually get when people are referred with blood in the urine. So this includes patients both with visible blood that the patient or the patient has seen themselves, or patients who've got microscopic hematuria when it's only found on a dipstick. And I suppose the first thing to say is that 62% of patients, we don't find anything wrong and they get discharged. The advantage about doing this in the context of this sort of clinic is this all happens in one visit, or in this case, in two. A few patients need to come back to have other little things sorted out, and occasionally we find another surprise cancer. But all of these patients needed an operation. These ones were operations for something other than cancer, and 13% of them actually had a new urologic cancer. So this is data in Western Australia with the GPs that you all know referring to this service. So there really is quite a high incidence of cancer with patients with blood in the urine. And this particular way, a little bit of this particular way of looking for blood in the urine in this sort of one-stop environment where we get all the tests and everything done on one day is a particularly effective way of doing this. And it would be nice to see, this is not a new idea, but it hasn't been very well taken up in Australia at the moment. So we're trying to promote this one-stop approach to blood in the urine as the best way for other centres, both in other places in this state and also in Australia-wide, to try and find the cause of blood in the urine quickly and effectively. So I'm going to start talking about bladder cancer first, and then we'll come on to prostate, kidney, testicular, and penile subsequently. This is a cystoscopic view of a bladder tumor. Okay, so the only way this is probably less than 2 or 3 millimeters across because it's quite magnified due to the effects of the cystoscope. But this sort of lesion in the bladder would be easily missed by a CT scan. Okay, so you can't actually find it just by having a CT scan. You do physically need to look with a telescope in the bladder if you want to pick up these lesions. So, just a few fast facts about bladder cancer. And this is the thing that concerns me the most at present, is that in Australia, survival for bladder cancer is actually getting worse. Now, bladder cancer has been sort of internationally is a little bit resistant to improvements, and it's certainly an area where we need to try and do better as a cancer. But this is the only major cancer in Australia where outcomes actually appear to be deteriorating. So for male bladder cancer, it's gone from 69% 5-year survival in this time period, patients from this time period, to only 62% in 1998 to 2004. And and has decreased by 10% in women. Another interesting thing about bladder cancer is it's one of the few cancers, even though it's much more common in men than women, it's one of the few cancers where women's outcomes are actually worse than men's outcomes. We don't really know why that is, but that's consistent across lots and lots of international data. The other thing about bladder cancer is no one's really heard of it, considering how much trouble it's causing. So I'm sure most people in the room would have heard of malignant melanoma, the sort of nastiest form of skin cancer that you can get, which we have a very, very high incidence in Australia, the highest in the world. Male bladder cancer, this is just looking at the chaps, is actually almost identical in terms of the numbers of deaths that it caused in Western Australia in 2009 to malignant melanoma. And I imagine that is a surprise to a few people. The other thing about bladder cancer is it's very expensive to treat because people, fortunately, most bladder cancer can be effectively treated, but people do need surveillance then for a very long time, including looking inside the bladder with telescopes and keeping that follow-up on them in the clinic. The other thing about bladder cancer is that though patients may have a low, less aggressive form of the disease for some time, sometimes it can go on and get worse and they need operations, or they may need chemotherapy or radiotherapy or other expensive treatments. So it really, in terms of the taxpayer and the cost to society, it really is very expensive to treat. The other thing is that cancer registry coding practices really do underestimate the burden of disease because they only include invasive cancer as cancer. So there's also the bladder cancer that I showed you on that slide earlier on. That might not be an invasive bladder cancer, in which case the cancer registry would say, well, that doesn't count because it's not invasive. The fact that it can go on and become invasive or can recur or can progress and become more serious is not recorded in the cancer statistics. So what are the risk factors of bladder cancer? Well, this is the main one. So smoking is the biggest identifiable risk factor for bladder cancer, and it's due to chemicals which are present in the cigarette smoke that are excreted in the urine. So all urothelial cancer, all cancer that affects the urinary tract, the lining of the urinary tract, is caused by exposure to carcinogens. And there are plenty of these in cigarette smoke, aryl amines. The other people who may get exposed to bladder carcinogens are people who work in the textile industry with certain special dyes, people who work in the rubber industry, people who work with diesel oil. So all of these things have been shown. Hairdressers are at a very slightly increased risk of developing bladder cancer because of their exposure to hair dyes. And then men, it's more common in men than women. As you get older, you get more chance of having it, and a family history is relevant. So what are the symptoms? Well, I think I've probably made the point about blood in the urine, and I hopefully don't need to go on about that too much more. But the other thing is recurring infections. Often somebody will go to the doctor with visible blood in the urine, and the doctor will diagnose an infection. The problem is that it might be the bladder tumor that's resulted in the urinary infection, and bleeding from a bladder tumor can be intermittent. So the fact that you had an infection, you've had antibiotics, and the bleeding's gone away temporarily, unfortunately, that doesn't exclude the fact that there might still be a bladder tumor. So patients, if you see blood in the urine, we need to look in your bladder. Also, sometimes bladder cancer just presents with urinary symptoms, wanting to go to the toilet frequently or in a rush, so that's much more commonly related to prostate problems. And obviously, with advanced disease, it can spread with signs of cancer elsewhere in the body. How do we treat bladder cancer? Well, if it's early disease, it can nearly always be successfully treated with a keyhole operation where we put a telescope down the water pipe, down the urethra, and remove the bladder tumor. Nearly always the patient will have a dose of chemotherapy then into the bladder, so not like when you have chemotherapy into a vein and it makes you feel lousy and your hair falls out and it makes you feel really sick, but actually just a local dose of chemotherapy into the bladder. And that may be all that's required, but the patient will need to be followed up in the long term. If it's found late, then they may need surgery to remove the bladder, sometimes radiotherapy. This is just a diagram showing how the bladder tumor can start off just on the surface. These two, the Cancer Council doesn't count, and this is about 50%. Sorry, not the Cancer Council, sorry, Terry. These ones, the Cancer Registry doesn't count, but these ones would be included, and this is about 50% of the disease. So if we do remove the bladder, we have to do something with the urinary stream. Now, sometimes we can plumb the ureters into a piece of bowel, which would then bring the urine out onto the skin in a bag. So like a colostomy, except that it's urine that's coming out of the bag. And that's the most commonly performed way that the urinary stream is diverted if you have to remove the bladder for bladder cancer. The other thing you can do is use some bowel to make a new bladder. It won't work quite like a new bladder because it won't be wired in the same way, but you fashion it into a bag. And then, this is quite hard to understand, this slide, even for me, but this is the bladder. If you imagine that the urethra and the penis is down here, and the legs are going up that way, and the head's up here, this is where the bladder should sit. This is the urethra, which is the tube that you pee through, and this new bladder is being sewn onto the urethra. And that can provide the advantages of not having to have a stoma. There are some disadvantages as well. While you're getting used to them, you have to strain to void, and you may get problems with urine being left behind in the bladder. And people have to accept the need. They may need to pass a catheter themselves to keep these neo-bladders, as they're called, to keep them empty at times. So that's all I'm going to say about bladder cancer for the time being. We've got a few more malignancies to get through, so I'm going to move on to prostate cancer now. Perhaps including some slightly controversial areas, which I will go through as fairly as I can. So, prostate cancer it's the commonest male cancer, and it's the second commonest cause of male cancer death. So that's highly significant. There are lots of people who do die every year of prostate cancer. However, we also know that there are lots and lots of people who have prostate cancer that never die of it. It certainly can run in families, and if found early, it can be cured. If it's very advanced prostate cancer that's spread outside the prostate, it probably won't be cured. But there are many, many treatments available which have a very serious and significant impact on this disease. So how does prostate cancer actually present? Well, in practice, someone comes along to their GP usually and says, look, I used to be able to pee like this, and now it's like this. Frankly, this nearly always, this isn't prostate cancer presenting. This is a man who gets older and the prostate becomes enlarged as they get older, and that enlargement causes a blockage and causes urinary symptoms. So this may often be how we find prostate cancer, but actually the reason it's presenting is because of a benign or a non-cancerous enlargement of the prostate. So these are the symptoms that people have. Frequency: going to the toilet often, being in a rush to get to the toilet, getting up at night. And then a weak stream, so the stream slows down or becomes a dribble. It may start and stop and start again. They may have to wait for it to start, something called hesitancy, and also a sensation that you can't quite get all the urine out of your bladder. Now, these are all the symptoms that you can have. But as I said on the earlier slide, these symptoms are nearly always being caused because of a benign enlargement of the prostate. So for your prostate cancer to actually block your stream, it would have to be pretty advanced and nasty. So nearly always, this is just the patient noticing symptoms because of the benign enlargement of the prostate. But nonetheless, patients who present with symptoms need investigating, and it's important for the urologist and for the patient, I'm sure, to exclude cancer or to diagnose it if it's there. So how do we do that? Well, I'm sure most of you will realize that if you come and see a urologist, it's pretty hard. If you're a chap, it's pretty hard to get out the door without them sticking a finger up your bum. And the reason for that is that we need to, that's the best way to examine the prostate is actually with a finger via the rectum. And you can feel the surface of the prostate, and if there's a hard lump on it, then that in itself is enough to go on and have more tests to try and diagnose prostate cancer. The PSA blood test is the next part of making a prostate cancer diagnosis. So this is something that you can measure in the blood just by taking blood out of the arm. PSA stands for prostate-specific antigen, and it is prostate-specific. So there's nothing else that makes PSA. So if we can measure high PSA, there's something going on with your prostate. It might just be big. You might have an infection. Somebody might have put a catheter in or done something else to disturb your prostate. Or you might have prostate cancer. It doesn't tell us which, it just tells us there's something wrong with the prostate. The only way we're actually going to diagnose prostate cancer is by taking some tissue. And this is done with an ultrasound via the backside, and then a needle fired into the prostate through the rectum to get pieces of tissue, which would then be sent off to a pathologist who'd look at them under the microscope and see if there was any cancer there or not. And he'd also give us that information about whether or not it was an aggressive cancer, which is so important when you're advising people how you might need to treat them. So how do we treat prostate cancer? Well, this could potentially be a long lecture, so I'm going to go through this relatively fast because there are a whole load of different ways in which you can treat prostate cancer. But essentially, if you're trying to cure the prostate cancer, your options are surgery or radiotherapy or active surveillance. So this group of people are going to be kept an eye on, if you like, with regular blood tests, regular PSAs, and perhaps a few more biopsies. But the whole point of active surveillance is if these people who seem to have disease that doesn't need to be cured now, if we watch them closely and things seem to be getting worse, they can still have surgery or radiotherapy and hopefully still be cured. In terms of surgery, we've got a whole different range of ways in we can do it, and the same with radiotherapy. So let's just have a quick look at some of those options. So surgery for prostate cancer. Open radical prostatectomy. This is probably the sort of gold standard, the mainstay treatment for prostate cancer. And it's only with this treatment that we actually have a randomized trial, which is where we compare treatment and non-treatment to show that you can actually improve survival by removing people's prostates. And this is the most commonly performed operation in Australia for prostate cancer. The cut is only just, the cut that you need to make to get at the prostate is from only just below the belly button. Obviously, there's still a wound to heal and to get over. And there can be side effects. Any way you remove the prostate, there can be some significant side effects, which I'll come on to. An alternative way to remove the prostate is what we call a laparoscopic radical prostatectomy. So this is where you have a similar approach, but instead of making a cut on the skin, you actually put in a number of different ports, which then allow operating instruments to go in and out, and a camera so that you can see what you're doing. This, like any other keyhole surgery, the main advantage is that you don't need to make such a big cut so that you can get, that may take some time to get over. The cut for this operation isn't very big anyway, frankly. The other potential advantages are you may get a bit less bleeding, and people may get back to work afterwards sooner. Fewer complications. I don't remember adding that to that slide. That must have been there already. The thing about laparoscopic surgery is that you're still doing the operation, but your instruments are outside. So there can be some issues with ergonomics, so it might be quite hard to do practically. And also, you may have you've got to interpret a three-dimensional field on the operating, what's going on inside on a two-dimensional screen, because you're only looking at a flat screen. So to get around some of those problems, some people have surgery with a robot where the operating surgeon, so this is the same idea as the laparoscopic approach, so you're trying to use a minimally invasive approach where you don't have a cut on the outside. This technology was actually developed by the American military, the idea being that robots would go onto the battlefield and operate on people while the surgeons sat having coffee somewhere else. If you had to be a military surgeon, that sounds very appealing, I must say, but it hasn't really got quite that far. But there is the people that make this machine, they have a bit of a world monopoly at the moment. It's extremely expensive and is aggressively marketed, often directly to patients as opposed to health providers. And the proposed benefits are, well, they have a system where you actually get a three-dimensional view of the operating that you're doing, which certainly is beneficial. And the fact that these robotic arms mean that you can make normal movements and then they're interpreted by the robot into very fine movements on the screen. So there can be some benefits in that. It removes any tremor if that were there, but it is somewhat expensive. And that's just an operative view. This is actually a robotic case. These are robotic instruments. So the surgeon's sitting at a console out sort of away from the patient, and he's controlling. This is a stitch that's about to tie off the veins above the prostate. So you can sort of get your view right in. When you're doing this operation open, it's quite hard to see under the pubic bone to do this bit of the operation. So those are some of the potential advantages. So what about radiotherapy for prostate cancer? Well, radiotherapy is high-energy X-rays, so they're just like the X-rays you have when you go and have a chest X-ray, except they've got a bit more oomph behind them. And in order to try and kill off cancer, the X-rays are focused on one area and fired from a number of different directions in order to get a big dose where the cancer is and try and minimize the dose to all the other structures, because obviously the radiotherapy is also not going to be very good for your normal tissues. And this is just a screenshot from one of these new 3D conform. So the radiation can be shaped in 3 dimensions. So if you're trying to fit it around a Satsuma, you can actually make the high dose fit around the curves of the Satsuma, or you don't have Satsumas, Clementine, or whatever size your prostate is. But the radiotherapy can fit around and try and reduce the doses to the other structures that are near the prostate. So you don't want to give too much radiotherapy to the rectum, for example, because that can cause serious side effects. And another way of getting the radiation just into the prostate is to physically put it in with a technique called brachytherapy. So this is where little seeds, which are actually radioactive, are physically inserted into the prostate, and they actually sit there forever. But when they first go in, they've got quite a high amount of radiation in them, and that comes out of the seeds and kills the prostate cancer. But because they're only in the prostate, it minimizes the dose to the surrounding tissues. So that's another technique. And then, just because the radiation oncologists wanted to have a robot as well as the surgeons, they've made this thing, which is another way of delivering radiotherapy, but in a highly shaped way at a very high dose. So this machine has ways of tracking exactly where the prostate is while it's giving the radiotherapy. And it can actually make adjustments in order, if you're moving slightly because you're breathing, which people tend to do, then the machine can make very, very fine adjustments to make sure just the prostate gets irradiated. So, the problem is all of these treatments have significant side effects. And if you have surgery, this isn't a side effect, this is a consequence. You will not ejaculate. If you've had your prostate and seminal vesicles removed, you can't ejaculate. So that's a consequence of the surgery. In terms of erectile function, this is 50% of people. This is people who have normal erections before surgery. Half of them, even with drugs, will still have problems with erectile function. So erectile difficulties, very, very common, whatever you do. And if you take all comers, it'll be much higher than 50%. So this is 50% for the people who started off okay. Urinary incontinence is relatively prevalent after prostate cancer surgery, but it depends when you look. So at a year after the surgery, most people are dry. Some people may be using one pad, but the patients who are wet, who are incontinent after prostate surgery, are normally pretty unhappy, and they may end up seeking other operations and other things to try and sort that incontinence out. And bowel side effects can occur, but are less common. With radiotherapy, bowel side effects tend to be the main problem, and they can occur early or late. Erectile difficulties nearly always happen, but down the track. So you may have your radiotherapy for prostate cancer, and your erections may be okay for a while, but they're quite likely to deteriorate after 18 months or 2 years. And that's because of the way radiotherapy works on nervous tissue, on the nerves that actually provide help to cause the erections. Urinary incontinence is less common as a consequence of radiotherapy, but can still occur. And other than you can have late radiotherapy side effects, and sometimes you can get a second cancer, which is actually caused by the radiotherapy that you had for the first cancer. The other issue with radiotherapy is you may get bleeding from the rectum, which can be very difficult to stop, and that can occur early or late. So what about advanced prostate cancer? Well, we have a very effective way of controlling prostate cancer for a period of time. Prostate cancer lives on testosterone. So it's actually a man's testosterone that drives prostate cancer. If you remove the testosterone completely, and you can either do this, you can do it surgically by operating on the testicles, or you can actually use a drug which blocks the production of testosterone, and that can control prostate cancer for a long time. At some point, the prostate cancer will start to grow again, despite you getting rid of the testosterone. At the point where you can't control prostate cancer by blocking testosterone anymore, then your options are chemotherapy, or a whole range of newer drugs, and there are lots of exciting new drugs for treating prostate cancer that's gone beyond the point of cure and beyond the point of control with hormones. And some of these, particularly these agents, are really very promising. Okay, so should we screen for prostate cancer? Well, this is a very difficult question, and just to outline the screening debate, imagine this is 100 men who are deciding whether or not to have a PSA test. The PSA test isn't perfect, but for a lot of them it will say, oh, that's fine, and they'll go off and they'll be happy. A few patients, the PSA test will think that they've got cancer and they haven't, and they'll be subjected to a biopsy that they didn't need, which might have a complication, but most likely they'll be fine, but they'll have had an unnecessary test and they'll have been a bit worried. The PSA test will miss prostate cancer in a small number of cases because it just didn't happen to be elevated in their cancer. And then you'll find some cases. Now, of these cases, not all of these guys would have been destined to die of prostate cancer. So, should we be screening? Well, screening with PSA and a rectal examination, well, screening just with PSA does reduce death from prostate cancer. That's been proven in large randomized trials. Prostate cancer, as we know, is a big cause of cancer death, and if it's detected early, it's more likely to be cured. And if it's found late, it's incurable. And we know that treatments are getting better in terms of the side effects they cause. But some men will be harmed by screening. Most men die with, not from, prostate cancer. And all of the curative treatments that we're potentially talking about have significant side effects. Now, unfortunately, we don't know which men will die from their prostate cancer and which ones won't. But just to put it in your minds, 80 on post-mortem studies, so these are patients who've died from some other cause and have been recruited, and they've allowed a pathologist to look at their prostate. 80% of patients who died from another cause had some prostate cancer. So some prostate cancer is almost a part of normal aging. So it's really important that you don't treat the cancer that doesn't need treating, but you do treat the cancer that does, because it's still the second biggest cause of cancer death. So I'll leave that mulling in your minds. We've got a couple more cancers to get through, but they are a little bit shorter than the last two. So kidney cancer. Traditionally, kidney cancer used to present with a pain in your side, a lump that could be felt by your doctor, and blood in the urine. Now, actually, most kidney cancers nowadays are actually found during an ultrasound scan or a CT scan that somebody's having for another reason. So we're finding what we call incidentalomas, these incidental tumours that we're not really sure about, but we know that they look like kidney cancer. And sometimes it's difficult to know which ones we need to treat and which ones we can safely observe. So there's a male predominance for kidney cancer, and this hasn't really changed. We still have a lot of people presenting late with kidney cancer, because often the lump in the kidney doesn't really cause physical signs until it's advanced. So some will be locally advanced, some will actually have disease elsewhere in their bodies. And it's increasingly detected, as I said, incidentally, because they're having an ultrasound or a scan for another reason. And that mass in the kidney often looks like cancer and usually is, but isn't always. And this is just an example of somebody who had a CT scan because they had a stone lower down in their ureter, the tube from the bladder to the kidney. And this lump, this is a normal kidney here, and here's a kidney with this lump in it, which looks pretty worrying. Now, actually, that lump was a benign lump. That was something called an oncocytoma, which is completely harmless. So sometimes, and there's a big debate about when or when not to biopsy renal tumours. But when they come like this, it's pretty obvious that they need treatment, and this was a large kidney cancer. You can just compare to the size of the fingers there, so that really was quite a large tumour. Kidney cancer has been a difficult area because the kidneys are so good at excreting things. They get rid of all the poisons in your body. They get rid of drugs. Almost everything that you consume that you don't want is either detoxified by your liver, comes out in your gut, or gets excreted by the kidneys. So they're used to getting rid of poisons and toxins. So if you give patients chemotherapy, unfortunately, the kidney cells are very resistant to it, and they can't get the drug into the cells. There was, for a while, something called immunotherapy was tried for renal cancer. It was very toxic, had a small benefit in terms of survival, but not a great deal. But fortunately, there are these new agents which are coming through, and there are ones coming through all the time that they're far less toxic, they really affect the kidney and its ability to get a blood supply and to grow, and they are improving survival. And we're looking into the roles of these agents in addition to surgery to get outcomes to be even better. And that's ongoing in trials at the moment. Testis cancer. So testis cancer is people think it's a disease of young men, but actually it's a trimodal distribution. So you have both young, middle-aged, and old men who can develop testis cancer. And generally, it presents with somebody noticing a lump in their scrotum. So this is incredibly important. If you feel a new lump, or a relative or somebody mentions, or someone knows they felt a new lump in the scrotum, they really must go to their doctor, be examined, and have an ultrasound. Just occasionally, testis cancer presents with people who are very unwell because the disease has spread elsewhere. But even when there's disease that's spread elsewhere, testis cancer has very, very high cure rates. Testis cancer, almost the opposite of kidney cancer, is very sensitive to chemotherapy. So even if there's disease all over your body, for example, Lance Armstrong, who's unfortunately been in the news for other reasons recently, but he actually had disease in his brain at the time when he was diagnosed, and he responded completely to chemotherapy. The actual disease testis cell is removed, and the amount of subsequent treatment you get depends on how bad your disease is. But really, this is the thing to remember. If you find a lump in the scrotum, you must go to your doctor. It's really important. Ultrasound is a painless and harmless way to look at what's going on, and will nearly always give a diagnosis just with a simple test that takes a couple of minutes. And testis cancer is usually cured. The last cancer that I'm going to touch on now is penile cancer. This is very rare, only about 10 cases per year in the state, but unfortunately they do tend to present late. So what we would really like is to see these cases of penis cancer being referred and seeing them earlier, or persuading patients to go to their doctor earlier so that we can treat them. Essentially, a lump, a red area, or a raised area on the penis, either on the glands at the end of the penis or the shaft of the penis, is concerning for penile cancer. And you really need to show that to your doctor, and they'll send you to see one of us so we can do a biopsy. Again, early disease can be cured, and I'm sure all the chaps would agree, early disease requires less extensive surgery. So really, if you want to have penile-preserving surgery for penile cancer, you have to find it early. The other thing about penile cancer is there's only 10 cases a year in the States, so it's really important that that's all done in one place. Our Fremantle Hospital actually is now the state referral centre for penile cancer, so we can try and concentrate the experience on those few cases in one place. And this is a principle that perhaps we'd like to apply to some other cancers in the future. Now, I've given you a lot of information in quite a short period of time, and I hope I haven't overloaded you too much. And I just want to go through a couple of take-home messages which I hope that you might take away with you and discuss with your family and friends. So blood in the urine needs investigating, and that investigation needs to involve somebody physically looking inside the bladder with a camera. If you find a lump in the scrotum, a lump or a red area on the penis, you should see your doctor. Okay? Men with urinary symptoms should see their doctor, who should do a rectal examination and a PSA blood test. Now, this isn't PSA screening. This is, you've got symptoms and you're going to the doctor, and doing your PSA will give him information about your prostate. It may tell him that the prostate's big. If he does a rectal exam and your prostate feels abnormal, well, that's very important information. So this is not screening. If you've got urinary symptoms, go and see a doctor who should do a rectal examination and a PSA. Screening for prostate cancer remains controversial. I have had my PSA tested, if you find that of interest. Okay, this is from the Find Cancer Early campaign from the Cancer Council, and you can notice that we've included problems peeing, a lump or swelling anywhere in your body, and blood in your pee. Notice this is in the once-off box, because you only have to have that once for us to be worried about cancer. I think this is an excellent campaign, and it's giving the sort of banner headline message really well. So don't be an ostrich. Most cancers are curable. Early diagnosis gives the best chance of cure. And early diagnosis means less chance of needing the major surgery, the major radiotherapy, and chemotherapy.
Thanks, Dickon. He's done a great job in rattling through that. We do have time for questions. We've got a roving microphone. Melissa up there in the blue top will be wandering around. So if anybody'd like to kick off with a question, we'd like to hear from this gentleman down the front. Furthest away from where she is, that's always the case. Well done, sir. Thank you for doing that. We need some exercise for the crew. Now, anybody else who has a question, if you can just catch my eye by waving your hand, I'll try and catch as many of you as I can. All right?
Thank you. Thank you for the lecture. I've been very well informed, but I have a question. Hypogonadism, or the shrinking of testes, what effect does that have on any form of cancer if the testes have shrunk? And is it possible in the future to do transplants of the prostate?
Okay, that's two questions. The first one to say is that hypogonadism is, we chemically or physically castrate people to treat prostate cancer. Now, the testes can shrink in themselves, and men can become hypogonadal in that they have a low testosterone. In terms of that and their effects on prostate cancer, it's unlikely to make them more likely to get prostate cancer. And if they had prostate cancer, it would be unlikely to make it worse. But nonetheless, if you have small non-functioning testes and you develop prostate cancer, we would still make sure we got rid of, unless you could have the prostate cancer cured surgically or with radiotherapy, we'd still need to make sure that you had all of the testosterone removed, because only small amounts of testosterone can still drive the prostate cancer. In terms of prostate transplants, I think it's unlikely in the foreseeable future or ever that we'll transplant the prostate, because you would probably be better off trying to find other ways to maintain erections or to treat the cancer or to help with the other side effects of the treatments that you put on prostate cancer rather than putting it back. So I don't think there'll ever be prostate transplants.
The lady in the middle there.
Thank you. I was just wondering, what's the wait time in terms of referral to your clinic at Fremantle? What sort of waiting time do people have before they're actually seen?
Which one? For the one-stop hematuria clinic?
Yes, that's it.
Okay, well, the wait time, the last time we audited it, it was about 20 days for visible hematuria and about 35 to 40 days for microscopic hematuria. We would like to see that time as 2 weeks for visible hematuria, but at the moment, resource constraints and everything else, we can't quite hit that. But it's still, we think, not too bad.
Professor Hayne, I've come down here today to see whether there's any chance there is an answer to a problem I have. I've been suffering from deferred radiation cystitis. I've had 8 weeks in the hyperbaric chamber down at Fremantle. I now have to self-catheterise 4 times a day because I have strictures in the prostate, but I can't stop. I'm continually incontinent. I just walk and drip. Is there any answer? I have damage to the sphincter, which means pubic catheter is not going to work because it will bypass it. I have actually gone down the road of asking about having the bladder taken out, but they say at 81 years of age and that you've got prostate cancer, you've had bowel cancer, you've got radiation cystitis, you've had radiation proctitis. They don't want to know. Is there any possibility of any answer to this, or have I got to walk around with a leg bag and pants for the rest of my life?
I mean, you've outlined a really desperately difficult clinical situation, because one of the problems with radiotherapy as a treatment at all is that it does affect the body's ability to heal. Now, surgical outcomes, when you have things go wrong after surgery, outcomes do tend to improve with time, and you can do other operations down the track if necessary. When you get radiation damage, the inherent abilities of the tissue to repair themselves is gone. So without a sort of consultation in the context of a lecture theatre, yes, I have removed people's bladders in exactly this situation as just a way of getting some control of the urinary stream. That can be very high risk in people who are elderly or who have had other surgeries or other things going on. Hyperbaric oxygen, I mean, lots of places don't even have access to that as a treatment. We're lucky to have that, but it doesn't always help. There are some, in terms of treating the continence, to put in a artificial sphincter is very risky in an irradiated field. So you really are stuck between a rock and a hard place, I'm afraid. If you wanted to pursue the options, they are quite risky options, such as more surgery or other treatment. So I don't know if that answers your question, but.
Just a general question. My husband diagnosed lymphoma last year, and he had chemotherapy last year, and he's on remission at the moment. And he had a PSA test the other day, and it was 6.5 or so. Is that, just as a general question, is one cancer trigger to another cancer, or any relationship between two cancers?
Sorry, what did he have for his prostate cancer? What treatment?
Lymphoma, non-Hodgkin lymphoma.
Oh, he had non-Hodgkin's
yeah.
lymphoma. Okay. Well, I think. So cancers they're all different. So all cancers are different. So if he's had lymphoma and treatment for that, whether or not he's got prostate cancer is a sort of completely separate issue based on his level of PSA. And if he's got a high PSA or his prostate feels abnormal, then he should need a biopsy. But it's a different cancer. The word cancer tends to make people quite frightened, but it is just another group of diseases. People are far less scared by heart failure or renal failure or heart attack, when actually all of these things can be really bad for you and can kill you. So it's sort of as bad as the one you've got. So I hope he's done well with his treatment for his non-Hodgkin's lymphoma, but whether or not he's got prostate cancer is a separate issue that needs to be investigated on its own rights.
Another general question. Lump is a very generic term. Lump in the testes, are you talking about swellings or hard features, or can you be a little more specific about what a lump means?
I think that's quite hard because, if you excuse the non-intentional pun, if most men have felt the contents of their own scrotum, so I think if you feel anything new, whatever it is, whether you think it's a lump or a swelling or whatever you might call it, I think you need to present to your doctor with that. Ultrasound is a very, very easy way of looking inside the scrotum. It's harmless, it's cheap, it's quick. And you'll probably get a diagnosis from that. To be more precise about testicular cancer, if there is a hard swelling in the body of the testis, which is the main sort of meat of the testis, that is very, very, very likely to be testis cancer if it's there. It's the most common cause of a lump in the testis. There aren't many other causes. So,
you spoke about taking testosterone out of the body. Can you tell me how long that will be? The long term. Is that long term for life, or is and what the effects are on the rest of your body?
Okay. Well, it certainly depends on the clinical situation. So you may have a period of androgen suppression, getting rid of the testosterone, around another treatment course, such as if you're going to give someone radiotherapy. So that might just be for 3 months, or it might even be for 2 or 3 years, but then stop. However, the majority of patients who have the testosterone blocked have it blocked because they've got prostate cancer that's spread around the body. In that situation, it is administered lifelong. So once you're on it, you're likely to stay on it. But you can, in some situations, you can give it intermittently. So you start and stop it to try and give people a break from all the side effects that you do get from having your testosterone removed.
Just a couple of questions. One, you didn't mention Gleason grading. Is that to be used in conjunction with PSA? And with radiotherapy or chemotherapy, if you use one, does that preclude the use of another further down the track?
Okay. So first of all, in terms of the Gleason grade, I didn't go into any of the specific gradings for the different cancers. But Gleason grade you can only get once you've got a bit of tissue. So the Gleason grade gazumps PSA massively in terms of telling you what you're likely to need to do. Because then, if you've got the Gleason grade, you know how aggressive the cancer is. So the PSA might tell you stuff about the likelihood of there being disease elsewhere, or just localized in the prostate. But the Gleason grade tells you how aggressive the actual cancer is. So that's absolutely key information. The second question was related...
Radiotherapy.
Oh, the order, that's right, yeah. So it's much harder to have surgery after radiotherapy, is the simple answer. So I commonly offer surgery to patients who potentially have aggressive advanced disease, because I think this is the situation where you make the most impact with an operation. Some of those patients will either have positive margins, they may have involved lymph nodes, or they may have another reason to give them another treatment as well, and they can go on and have radiotherapy. Now, of course, once you have both treatments, the side effects start to increase. But in terms of can you have salvage surgery after radiotherapy? Yes, sometimes, extremely rarely. So it's much more commonly the other way around.
This is one down the front, if we can make that a quick last question.
Thank you. You haven't mentioned a vasectomy. There's a lot of people having vasectomies for control of childbirth, etc. Does it have a positive or negative effect in the long term?
I would say that would depend whether or not you thought it was a good idea not to have any more children. I mean, in terms of, I don't believe there's any association between vasectomy and prostate cancer. If that's the base, there was some stuff in the literature, and I think it's been debunked. So no, I don't think having a vasectomy causes prostate cancer. Vasectomies can cause lots of problems in their own right. People having problems with pain afterwards or asking for a reversal. But I don't believe there's any realistic association with either testis or prostate cancer. Though it has been suggested, you're right, but I don't think that's correct.